Hello everyone. Today we will speak about renal tumor part 3, and this lecture is very important in management of patient with renal tumor. So let's start first by the follow-up after partial nephrectomy or radical nephrectomy for localized RCC. The majority of recurrence occur within 3 years after nephrectomy. Laboratory tests are obtained routinely that include blood urea nitrogens, creatinine, and ESR or estimated glomerular filtration rates. Urine analysis, other laboratory tests are obtained at the discretion of the physician and may include liver function tests, alkaline phosphatase, lactate dehydrogenase, and serum um, calcium. Okay, so we will do this blood urea nitrogen, creatinine, ESR, and urine analysis. And other laboratory tests, this is include, as I mentioned, LFT and alkaline phosphatase, lactate dehydrogenase, serum calcium. In patients with less than one whole kidney perform periodic 24-hour urine for creatinine, protein, volume to assess for hyperfiltration injury. Bone scan is recommended when the alkaline phosphatase is elevated and patient has skeletal symptoms such as pain. Other imaging suggests the presence of bone lesions. Imaging of the central nervous system is recommended when there's acute onset of neurological symptom, sign and symptom. So follow up during the first 5 years after partial or radical nephrectomy if microscopic positive margin is present. That's increase the risk of risk categories at least one level higher. So we have the risk classification to show it for you in details. We have low risk. This is PT1 grade 1 to 2 and N0 M0. This is low risk. So this consider BT1 or tumor grade 1 2 with no lymph nodes. This is considered as low risk. And we will do history examination and lab test and abdominal CT or MRI with or without IV contrast and chest X-ray as follow. First, second, and 4 and 5 years after surgery, and when clinically indicated. If indicated, we will do this. This must be done with this manner. We will do history examination and lab test plus abdominal CT or MRI with or without IV contrast and chest X-ray. This will be in the first year, second year, and the fourth year, and the fifth year after surgery. Or when it is clinically indicated, after 2 years, the clinician may consider alternating between the abdominal ultrasound and abdominal cross-sectional imaging CT or MRI. And then we'll come to intermediate risk. That's BT1 grade 3 to 4, grade 3 or grade 4 tumors, or BT2 any grade, no lymph nodes, no MITs. We will consider doing history examination, lab test, and abdominal CT and MRI with and without IV contrast and chest X-ray. All this must be done for those 6 months, and then in the first year, second year, third year, and first year, and fifth year after surgery, or when clinically indicated. This is for intermediate risk. It's very clear. Then after 2 years, the clinician might consider alternate between abdominal ultrasound and cross-sectional imaging. The high risk, that's BT3, any grade, no lymph nodes and no MITs. N0, M0, we will do history and examination and lab test, abdominal CT and MRI with or without contrast, and chest CT. In this patient with high grade, we will do chest CT, not chest X-ray as previous low grade or intermediate risk. Here we will do chest CT. This must be done with 6 months, 12 months, 18 months, in 24 months, in 30, 36, 48, and 60 months after surgery must be in this manner, and or when clinically indicated. This is for high grade or T3 or any grade at high risk. So this we will do this evaluation by history examination, lab test, abdominal CT or MRI visual result contrast, and chest CT during the 6 months, 12 months, 18 to 24, 30, 36, and 48, and 60 months after surgery, or when clinically indicated in this grade. So a very high risk, that's BT4, N1, M0, or sarcomatoid type, or macroscopic positive margin. If this is available in your patient, you must do history examination, lab test, abdominal CT or MRI, chest CT, as well as high risk. The very high risk also will do chest CT, but here we will start by 3 rather than in the high risk. We start by 6 months. Here we will start by 3, 6, 9, 12, 18, 24, 30, 36, 48, and 60 months after surgery or when clinically indicated. This is for very high risk. The follow-up beyond 5 years after partial nephrectomy or radical nephrectomy. After 5 years, you will do abdominal and chest imaging are optional. Here it's optional for the clinician or for urologist, but the history examination and lab should be obtained every 6 to 7 years and at 8 to 10 years after surgery. So 6 to 7 years after surgery, or and at 8 to 10 years after surgery. This is for after 5 years. After 5, it's optional to do abdominal or chest imaging, but the history examination and lab, and this must be done at 6 to 7 years, and then 8 to 10 years after surgery. Imaging beyond 5 years might be most appropriate for patients with high risk cancer. So for those with high risk or very high risk, it is better to do for them imaging, abdominal or chest imaging. If chest imaging is continued beyond 5 years in high risk or very high risk patients, we will start by chest X-ray, may be considered rather than chest CT. So after 5 years, it is better to do a chest X-ray rather than a chest CT. Additional testing should be obtained when clinically indicated. Patient with solitary kidney should be advised that participation in contact collisions for places the kidney at risk for traumatic injury. Need to avoid contact and collisions sports is determined on the individual basis for those groups. This is a follow-up in details. So we speak about the majority of the RCC recurrence occur within 3 years after nephrectomy. A laboratory test, blood urea nitrogen, creatinine, ASR, and urine analysis or obtains, plus other might be. Bone scan is recommended. Alkaline phosphatase, if elevated, is elevated, and when the patient's skeletal muscle or patient with bone lesion. So if the patient have elevated alkaline phosphatase or have skeletal symptoms or presence of bone lesions, we will do bone scan, imaging of the central nervous system if the patient have acute onset of the neurological sign and symptoms. So follow-up during the first 5 years after partial or radical nephrectomy is divided to low risk, intermediate risk, high risk, and very high risk. Low risk, here we will do history examination, lab and abdominal CT, MRI with or without contrast, and chest X-ray at first, second, fourth, and fifth year after surgery. And then according to the clinical needs. And the intermediate risk here, this is, as you see here, BT1, 3 to 4, BT2, any grade, M0, M0, history examination, and abdominal CT, MRI with or without contrast, and chest X-ray at 16 months and at 1 and 2 and 3rd and 4th and 5th years after surgery or when clinically indicated. And a high risk, this is T3 and T3 any grades, N0, M0, history examination, lab test, abdominal CT and MRI with or without contrast, and chest CT at 6, 12, 18, 24, 30, 36, 48, and 60 months after surgery. So for very high risk groups, that's BT1, BT4, in one here sarcomatoid type or macroscopic positive margin, we will do the same history examination and lab and abdominal CT or MRI, and here we will do CT chest, as well as in this patient with very high risk or any patient with T3 any grades. But the follow-up here is different, as you see here. In this stage, start by 6 months. Here we'll start by 3 months, then 6, then 9, then 12, then 18, then 24, then 30, then 36, and then 48, and then 60. So this is different from this. It starts by 6, here starts by 3, and here we have 6, 12. Here directly you have 6, 9, then 12. But after that, it looks same, no difference, is the same. Okay, so just the difference that here we start by 3 and we have 9, but here start by 6 and 12. This is for high risk group, and this is for very high risk group. Treatment of metastatic RCC. RCC with oligometastasis. Oligometastasis is the presence of few metastasis. Example that less than 3. If we find less than 3 oligometastasis, this is considered as presence of few metastasis. In patients with oligometastasis, long-term survival has been achieved when the primary and metastatic lesion were treated. So when the oligometastasis present sometime as primary RCC, the preferred treatment is excision of the primary tumor and the metastasis. This is for oligometastasis. When oligometastasis develop after nephrectomy, local recurrence in renal fossa or other metastases, the preferred treatment is tumor resection. So this for oligometastasis after nephrectomy. When resection of the metastasis is not feasible, then the metastasis might be treated with ablation or radiation, depending on the metastasis lesions. So another option is systemic therapy for those groups. So for those groups, if the metastasis is not visible for resection, we will what we will do, we'll do ablation or radiation, depending on the metastasis locations. And another option is systemic therapy or chemotherapy. When oligometastases are resected, the prognosis is better when the metastasis occur in the lung rather than in the another location, for example, brain. The metastasis arise after nephrectomy initial stage M0 compared to when the metastasis presents with the primary tumor, that initial stage M1. So if we have metastasis arise after nephrectomy compared to when the metastasis present with the primary tumor, this is considered as the better prognosis. Okay, if to the lung or if the metastasis arise after nephrectomy, initial stage M1, M0. RCC, we spoke about the oligometastasis RCC, and then we will speak about the RCC with non-oligometastasis. Patient with metastatic RCC carcinoma can be classified into the risk category using either Memorial Sloan Kettering Cancer Center prognostic models, or known as MSKCC, or International Metastatic Renal Cell Carcinoma Database from Constrom criteria, or IMDC. So these two models and criteria, it's actually used to classify the non or metastatic RCC. So patients with metastatic renal cell carcinoma can be classified into the risk categories using these two classifications. The models, Memorial Sloan Kettering Cancer Center prognostic models, and International Metastatic Renal Cell Carcinoma Database for Nostrom's criteria. So cytoreductive, we will speak about cytoreductive nephrectomy. This defines as radical nephrectomy in M1 patient before administering systemic therapy. So if we do this, this is known as cytoreductive nephrectomy. That means we will do radical nephrectomy in M1 patient before administering any systemic therapy. Radical nephrectomy is performed to reduce the tumor burden. So in M1 patients, two randomized trials that shows the radical nephrectomy followed by interferon improved time to progression and also overall survival compared to interferon alone. So this is in patient with M1. Patient with M1, we have two randomized trial show that the radical nephrectomy followed by interferon. This is improve the time to progression. Improve the time to progression first, and then overall survival. So if we use to do radical nephrectomy and interferon together, this will improve time of progression and also overall survival compared by interferon alone. Currently, interferon is rarely used to treat metastatic disease, and there have been no randomized trial specified or specifically addressing cytoreductive nephrectomy with newer agents. However, that suggests that the patients with intermediate risk or high risk metastatic RCC do not benefit from cytoreductive nephrectomy before tyrosine kinase inhibitor therapy compared to tyrosine kinase inhibitor therapy alone. So the cytoreductive nephrectomy is an option for some patients with low risk metastatic RCC. So cytoreductive is an option for low risk. It's appeared that the patients most likely to benefit from cytoreductive nephrectomy have good performance status, example ECOG performance status 0 or 1, no brain metastasis, or metastasis only in the lung. Those groups have a benefit from the cytoreductive nephrectomy. Cytoreductive nephrectomy is have a good prognosis in those groups. Good performance status, example ECOG performance 0 or 1, no brain mets, or only the mets to the lung. Palliative treatment of a primary tumor when primary tumor causes and significant symptom, example pain, gross hematuria, or nephrectomy or tumor embolization may be performed in order to control cancer-related symptoms. So the palliative treatment, we will do it when the primary tumor causes significant symptoms, and the nephrectomy for or tumor embolization as option as palliative for those patients can be performed in order to control cancer-related symptoms. Radiation is not effective for primary tumor control. So first line treatment for metastatic clear cell renal cell carcinoma, the first systemic treatment for those patients with metastatic clear cell carcinoma, RCC or clear cell renal cell carcinoma, we have a favorable or low risk. This will be referred the regimens of bazogenib and suntinib and cabozantinib and infigratinib and levo. This is all this consider bazogenib considered as option, suntinib as options, and also we have cabozantinib as option. But the cabozantinib we will use with it nivolumab. This is with cabozantinib. And another option as first choice, levantinib plus pembrolizumab and levantinib and pembrolizumab. Both this is an option. The second, the second. This is the first, and this is second, and this is as a cabozantinib and nivolumab. Those as a second third option. This is the first option. Or we will use the second group. This is axitinib plus pembrolizumab. And this is the first option. Bazogenib. The bazogenib have a dose of 200 and 400 milligrams. Or we will use suntinib. Suntinib have a dose of 12.5 or 25 or 50 milligrams. or we will use both this group, cabozantinib and niflumab, cabozantinib and niflumab as one group, or we will use levintinib and bimbrolizumab, both groups. This is an first option for patient with metastatic clear cell carcinoma. This is the first option. The second, we will use the second option is axitinib and pembrolizumab. Okay, so this is axitinib and pembrolizumab. And axitinib 5 milligram on 10 milligram is available. Okay, this is pembrolizumab available in 100 milligram. This is the mechanism of action of chemotherapy that use or systemic chemotherapy use in clear cell RCC. As you see here, this is levintinib. It's act on FGFR, as you see here. And we have suntinib, bazopenib, and exitinib, and levintinib, and sorafenib. All these acts on BDGFR and FEGFR. Okay. And we have cabozantinib. This act on AXL and c-Met, and also act on VEGFR, and also act on c-Met and AXL. This is cabozantinib. Everolimus and temsirolimus, this is also acts on mTOR. We'll speak about it later on. And here we have also ipilimumab. This is act on CTLA4. This is atezolizumab act on BDL1, and niflumab act on BD1. This is the niflumab act on BDL1. All right, this is all important. And we have, this is here, bevacizumab act on VEGF. This is bimbrolizumab act on BDL1 and BDL1 receptor. This is the tumor, and this is the receptor, BDL1 and BDL2. This is bimbrolizumab act on this. And this is sunitinib. Sunitinib act on this tyrosine kinase, act on the kinase, act on kinase activation, inhibit kinase. No kinase activation is known as sunitinib or tyrosine kinase inhibitors. As you see, this is the normal, and this is the abnormal. Here we will inhibit it. Other recommendation regimens, ipilimumab and nivolumab, or we'll use, this is all both together, and or we will use cabozantinib or axitinib plus avelumab. Used in selected cases, we will use high dose of interleukin or axitinib. This is another recommendation for management of systemic metastatic RCC clear cell. This is for the other recommendation. We have ipilimumab and nivolumab. This is ipilimumab. This is we have 200 and we have 500 of ipilimumab. Ipilimumab is 200 and 500. And we have niflumab. It is actually 100 milligram and 40 milligrams. This is also another option alone. It's known as cabozantinib. It is have 3 divided dose to 20, 40, and 60 milligram. Axitinib, this is axitinib, and also avelumab. This is another option, and this is avelumab is a dose of 200 milligram. Intermediate or poor risk preferred regimens, we will use cabozantinib and nivolumab as a first option, or we will use ipilimumab and nivolumab. This is also as a second option. Combination of this and combination of this is also available. Or axitinib and bimbrolizumab. This is also combination of this available for intermediate or poor risk. The last, we will use levintinib and bimbrolizumab as a third option. This is for intermediate and poor risk. This is clear. cabozantinib and nifluzumab. Both this is as a first combination. The second combination is imblumab and niflumab. The niflumab, both this is this and this is a imblumab and niflumab. This is considered as combination. Also, axitinib and pembrolizumab, this is also considered as combination. The levatinib and pembrolizumab, this is considered another combination. Other recommended regimens, that's bazogenib and sunitinib or axitinib plus avelumab, used in selected cases high dose of interleukin or axitinib or temsirolimus. This is in selected cases. The first line systemic treatment for treatment of metastatic non-clear cell RCC, preferred regimens, the clinical trial or sunitinib. Other recommendation for those group non-clear RCC, we can use these regimens, cabozantinib or everolimus or levatinib plus everolimus. This is as combination. Used in selected case, many options are available, including erlotinib or bevacizumab or temsirolimus, etc. All this is used in selected case. For intermediate risk patients who respond well to the first line systemic therapy, long-term sustained response and minimal residual metastasis, then nephrectomy may be considered. This option is based on data from the SureTime trial, which randomized patients with metastatic clear cell RCC to immediate cytoreductive nephrectomy followed by sunitinib, or to deferred nephrectomy, sunitinib administered first, then the nephrectomy if there was no progression on sunitinib. Overall survival was longer for patients in deferred nephrectomy group. So those groups have a longer survival compared with patients who have underwent immediate cytoreductive nephrectomy followed by sunitinib. This is in this trial known as SureTime trial. This is for metastatic clear cell. Chemotherapy is ineffective for most types of RCC, unfortunately. However, it has shown modest activity in medullary RCC and collecting duct RCC. So this is have a modest activity in these types of RCC. Oral targeted therapies, example tyrosine kinase inhibitors, are not effective for renal medullary RCC. Either clinical trial or systemic chemotherapy is the treatment of choice for metastatic medullary RCC. So the best is to do clinical trial or systemic chemotherapy. This is as an option, is the best way. Systemic therapies are poorly effective against brain mets. Brain mets metastasis might be treated with radiation or surgical resection, especially if there is symptomatic or growling. So if the patient has symptoms or growling, it's better to do resection for the secondary brain RCC. Radiation may be used for palliations of bone and brain mets. Tyrosine kinase inhibitors. Tyrosine kinase inhibitors reduce angiogenesis and cell proliferation. So these tyrosine kinase inhibitors, the mechanism of action, it will lead to angiogenesis and cell proliferation. They inhibit various tyrosine kinases such as vascular growth factor, that's FEGFR, and platelet derivative growth factor receptors, that's BDGFR, and stem cell factor receptors, that KIT. This is a stem cell factor receptor. Tyrosine kinase inhibitors are indicated for the treatment of advanced or metastatic RCC. Tyrosine kinase appear to improve median progression for survival by 2 to 6 months, and also median overall survival by few months. This is overall and this is median progression for survival by 2 to 6 months. This is improved by tyrosine kinase. Example of tyrosine kinase inhibitor suntinibs or sorafenibs or bazobenibs, axitinibs, or cabozantinibs or libuntinibs or erlotinibs. All this is an example for tyrosine kinase inhibitor. Compared to suntinibs, bazobenibs causes less fatigue, less hand and foot syndrome, less alert test, and less thrombocytopenia, better quality of life, but have high risk of elevated LFT. This is compared to suntinibs. That's this. Bazobenibs have this less fatigue, less hand and foot syndromes, less alert tests, and less thrombocytopenia and better quality of life, but have higher risk of elevated LFT. Both bazobenibs and suntinibs are options for first-line treatment of a low-risk metastasis clear cell RCC. So this is the bazobenibs and suntinibs are options for first-line treatment of low-risk metastatic clear cell RCC. The tyrosine kinase inhibitor side effect is skin reaction, hand and foot syndromes, gastrointestinal vomiting, diarrhea, elevated amylase, elevated LFT, or liver function, and alert test. Also lead to hypophosphatemia, hypothyroidism, and hypertension and proteinuria. Remember, all this can occur, but the skin reaction and hand and foot syndrome occur. Gastrointestinal that include vomiting, diarrhea, elevated amylase, elevated liver function, and alert test, plus a hypophosphatemia and hypothyroidism, hypertension, and proteinuria. So 3HB, remember HB, the HB associated with TKI or tyrosine kinase inhibitor. HB, that's hypophosphatemia, hypothyroidism, plus hypertension, so and proteinuria. Always with hypertension, we will find urine have cross of protein, so proteinuria is also considered. Another that's bleeding, hemorrhage, thrombocytopenia, neutropenia, alopecia, headaches, fatigues, embolic event like stroke and myocardial infarction might have been. Low ejection fractions, cardiac ischemia, and prolonged QT interval has been reported with this. During therapy check, we will do check for blood pressure, CBC, or complete blood count, urine analysis for protein, thyroid function test, serum chemistry, sodium, potassium, phosphates, creatinine, liver function test, amylase, lipase. Also, we'll monitor of ejection fraction can be considered. Since this medication impair angiogenesis, they can interfere with wound healing. To avoid poor wound healing, stop tyrosine kinase before elective surgery. You will stop it before elective surgery because this medication impair angiogenesis and can interfere with wound healing. Do not resume the tyrosine kinase inhibitor until the wound healing is adequate. The time frame in which tyrosine kinase is stopped before and after surgery depends on the tyrosine kinase being used. Immune checkpoint inhibitors. The immune checkpoint inhibitors are medications that block an important regulatory step of the immune systems. This medication typically reduces tumors' ability to evade the immune systems, which allow the immune system to more effectively attack the cancer. We have BD1 and BDL1. This is pathway inhibitors. Example for BD1 and BDL1 in pathway inhibitors includes pembrolizumabs and nivolumabs and avelumabs. So it is a lumab family. That's lizumabs, lumabs, nivolumabs, avelumab, nivolumabs, and pembrolizumab. This is known as a BD1 and BDL1. The programmed death receptor 1 is located on lymphocytes. So these drugs here, pembrolizumabs or nivolumabs or avelumabs, this is act on these receptors is known as programmed death receptors. The programmed death receptors located on lymphocytes, that's why L here, L1, lymphocytes. When certain protein bind to PD-1, the immune system has reduced capacity to attack normal tissues, decreasing the autoimmune reactions and reduce capacity to attack malignant tissue, hindering the body ability to kill cancers. PD-L1 programmed death ligand 1 is protein that binds to the PD-1 receptor, is known as programmed death ligand 1. May cancer evades the body's defense by expressing a high level of PD-L1, which bind to PD-1 and inhibit the immune system ability to kill the cancer. Medicine can block the binding of PD-L1 to PD-1 by attaching to the PD-L1 inhibitors or by attaching to the PD-1 receptors inhibitors. However, both PD-1 inhibitors and PD-L1 inhibitors indicate anti-cancer effect by inhibiting the PD-1 and PD-L1 pathway. The increased immune activity from blocking the PD-1 and PD-L1 pathway can also result in attacking on normal tissue, which lead to some of the side effects. All PD-1 inhibitors and PD-L1 inhibitors block the same pathway. They all tend to have a similar side effect. We'll come to CATLA or CTLA-4 pathway inhibitors. Example of this, we have ipilimumab or ipilimumab. This is CTLA-4 cytotoxic T lymphocytes antigen 4 is a protein receptor on activated T cell. Is known as ipilimumab. The ipilimumab, this is CTLA-4 cytotoxic T lymphocyte antigen 4. It is protein receptor on activated T cell lymphocyte 4. Under normal circumstances, a ligand bind by cytotoxic T lymphocytes antigen 4 receptor and downregulate the cytotoxic activity of T cell. We have ipilimumab is a monoclonal antibody that binds to CTLA-4 receptor and block down regulation of cytotoxic activity, which increase the immune system ability to kill the cancer. The mammalian target of rapamycin inhibitor is known as mTOR. The mTOR is protein that regulates hypoxia inducible factor, is known as HIF, and vasoendothelial growth factor. So we have this protein, it's regulate hypoxia endothelial growth factor and vasoendothelial growth factor. This is known as mammalian target of rapamycin inhibitors. When the mammalian target of rapamycin inhibitor is inhibited, the drug inhibits this mammalian TOR of rapamycin. The inhibition lead to decreased vasoendothelial growth factor because it's regulate vasoendothelial growth factor, and also so it regulates hypoxia. So hypoxia endothelial growth factor or hypoxia endothelial factor is decreased too, which reduces the cell proliferation. So decreased vasoendothelial growth factors, this will lead to angiogenesis, and decrease hypoxia endothelial factors, which will reduce the cell proliferation. So here we have reduced in angiogenesis due to decrease in vasoendothelial growth factor, and here we have reduced in cell proliferation due to decrease in hypoxia endothelial factors. Thus, mTOR inhibitor reduce angiogenesis and cell proliferations. Temsirolimus and everolimus inhibited inhibits mTOR. This is a good example for mTOR inhibitors or mammalian targeted of rapamycin. Mammalian targeted of rapamycin inhibitors. This is a good example, temsirolimus and everolimus. Temsirolimus is FDA approved for treatment of advanced RCC in patients with predictors of short survival. So if the patient have a short survival, it is better to use temsirolimus. This is FDA approved for advanced RCC. Everolimus, this is FDA approved for treatment of advanced RCC after failure of sorafenib or sunitinib. If we have failure of sunitinib or sorafenib, it is better to use everolimus. Everolimus is also FDA approved to shrink angiomyolipoma. So for angiomyolipoma, it is better to use Evro. Evro, it is for angiomyolipoma in patient with tuberous sclerosis or whose angiomyolipoma does not require surgery. If have a tuberous sclerosis or it's not require surgery. mTOR inhibitor side effects include rash, sarcomatoids, and infections, athenia, that's weakness, and peripheral edema. GI symptom, nausea, vomiting, diarrhea, anorexia can occur. Hematological thrombocytopenia, neutropenia, anemia can occur. Hyperglycemia and hyperlipidemia and elevated creatinine, elevated liver function tests, and hypophosphatemia, all this can occur. But remember, the patients with temsirolimus commonly develop diabetes. Temsirolimus. Also, the side effect of this is everolimus include all this, plus hyperglycemia, hyperlipidemia, elevated creatinine, elevated LFT, hypophosphatemia, GI problem, hematological thrombocytopenia, anemia. A rare side effect include bowel perforation, interstitial pneumonitis, cough, dyspnea, hypoxia. Interleukin-2, a cytokine that stimulates cell-mediated immunity. It was one of the first FDA-approved treatment for advanced RCC, but it's rarely used now because of a toxicity and it limits effectiveness in most patients. Interleukin-2 is used to treat clear cell RCC. Other type of RCC usually do not respond to interleukin-2. To be a candidate for interleukin-2, the patient must know the patient must have no brain metastasis and have adequate cardiac, renal, and pulmonary function. A good performance status of that ECOG-BS less than 2, or a patient predominantly clear cell carcinoma or absence of sarcomatoid feature, or those group are preferred. The most effective regimens is a high dose bolus of interleukins. Each cycle consists of intravenous interleukin 600,000 to 720,000 international unit per kg, Q 8 hours for 14 dose. Okay, so this is a candidate for interleukin. The candidate for interleukin, if the patient have no brain mets and have adequate cardiac, renal, and have good performance, and also an absence of sarcomatoid feature. All those is very fair for interleukin-2. Patient must have no brain metastasis or have adequate cardiac, renal, and pulmonary function, have good performance status that ECOG-BS less than 2, predominantly clear cell carcinoma, absence of sarcomatoid features are preferred. The most effective regimen is high dose of bolus of interleukin 2. Each cycle consists of intravenous interleukin of 6,000, 600,000, 720,000 international per kg, QDS every 8 hours for 14 doses. 2 cycles are given within 5 to 10 for 9 days of rest in between cycles. In responding patients, this 2-cycle course is repeated every 6 to 12 weeks. Side effects of interleukin include fever, chills, weight gains, fluid retention, reversible renal and hepatic insufficiency, hypotension. Response rates equal 16%, 5% complete response, 11% have partial response. Okay, so this is the total response is 16. Of this 16 response, we have 5 this is complete response and 11 partial response. Criteria that predict a better response to interleukin 2, as I mentioned here, we have ECOG, a BS of 0, absence of metastasis in multiple organs, no POM-MITS, lung MITS only, biliary nephrectomy, and no sarcomatoid feature in primary tumors. Interferon is less effective than interleukin 2. Bevacizumab with interferon alpha 2A. This is bevacizumab, recombinant monoclonal antibody inhibitors. So it is recombinant monoclonal antibody. This inhibits angiogenesis and tumor growth. That's by binding to and neutralizing the vascular-endothelial growth factors A. This is a bevacizumab. The bevacizumabs, this is recombinant monoclonal antibody that inhibit angiogenesis and tumor growth. This is the bevacizumab with this is bevacizumab. So this group it's come together. Bevacizumab interferon alpha 2A is FDA approved for treatment of metastatic RCC. In patients with clear cell RCC, bevacizumab with interferon alpha 2 improve progression-free survival by 3 to 5 months compared to interferon alone, but it did not improve overall survival. Bevacizumab interferon is more effective than interferon alone. Most patients that were studied had a previous nephrectomy. Side effects include dry mouth, headache, hypertension, stomatitis, and gastrointestinal that lead to dyspepsia. So stomatitis and mouth ulcer that's occur, and gastrointestinal it will lead to dyspepsia, anorexia, and constipation. Dyspnea can occur, voice change, minor bleeding, poor wound healing associated with bevacizumab. Dry mouth and headaches, hypertension, and stomatitis, and gastrointestinal that lead to dyspepsia, anorexia, and constipation, dyspnea and voice change, and minor bleeding, and poor wound healing. But the rare side effect of bevacizumab include bowel perforation and hemorrhage. To avoid the poor wound healing, stop bevacizumab at least 28 days before elective surgery. It may be resumed at least 28 days after surgery. So 28 days before and 28 days after. This is the treatment of the RCC adopted here by NCCN and AUA and EUA guideline. We will decline the treatment so we will decline the treatment unfit for treatment or patient short life expectancy. So if this available, is available, we will do surveillance only. If the patient have declined treatment, unfit for surgery or treatment, or short life expectancy, we will do surveillance. If no, this is for No, that's M0 or M1 with oligomets. We'll do radical or partial nephrectomy, resect the tumor thrombus if present, plus or minus regional lymph node dissection. And the lymph node dissection, it's actually performed this lymph node dissection. Also, we will do adrenalectomy, and this is a treatment treat oligometastasis if present. Okay, so this is for this groups. If no gross residual RCC, positive margins or positive, when the positive margin is present, repeat resection may be considered for patients with aggressive tumors or negative surgical margin. So this is unresectable. For unresectable gross residual RCC, we will start systemic therapy. For metastasis RCC inside the CNS is symptomatic or growing, administrate radiation or resect the lesion. If no gross, we actually, if the clear cell RCC and high risk for recurrence, consider adjuvant suntanibs, and high risk include any of the following: stage T4 or regional lymph node metastasis, or S stage T3 and 0 or 4 months more than or equal to, or ECOG performance more than or equal 1. We will do surveillance for groups, for these groups, and surveillance we can do local or oligo metastatic recurrence, treat the recurrence by surveillance, and if surveillance no oligomets recurrence, non-oligomets recurrence, we will start systemic therapy. And for metastatic RCC inside the CNS, we will do the same symptomatics or growing. We will administrate radiation or we will do resection. This is for this group. Is unresectable gross residual RCC, we will do this. Then we come to the group of no. Here we have M1 with non-oligomets. This is with oligomets. Here we'll do biopsy and metastasis of the primary tumors to make diagnosis of RCC. That's a less palliative or cytoreductive nephrectomy is planned. So is primary tumor causing significant symptoms, as for example pain or hematuria? Yes, we'll do palliative embolization or nephrectomy. If no, it is not causing any symptoms, we will do check is it low favorable risk, consider cytoreductive nephrectomy. If intermediate or poor risk, we will do systemic therapy and we'll check the brain for the another option. This is a key for each table in this or box in this guideline. Recurrence and survival. Recurrence after curative treatment for primary RCC after partial or radical nephrectomy. Local recurrence in the renal fossa is rare, less than 2%. Resection of local recurrence in the absence of metastatic disease can be achieved long-term survival rates. In the absence of genetic and familial RCC syndrome, recurrence in contralateral kidney is rare, less than 2 to 4%. This is in the absence. Lung is the most common site for of the distant recurrence. So it is for distant recurrence, this is the common. But the most common is the organ sites, it's different. We'll speak about it in the previous lecture. And this is lung is the most common site of distance recurrence. Most recurrence occur within 3 years after treatment. Poor prognostic factors of RCC, and this is actually ECOG PS, that poor prognostic factors. ECOG's activity, we have 0 that normal activity, 1 symptomatic but ambulatory, 2 bedridden less than 50% of the time, or sorry, bedriddens. Bedriddens more than 50, bedriddens more than 50% at the time. And 4, this is completely bedridden. So this is 0, normal activity, 1, symptomatic but ambulatory, 2, it's bedridden less than 50% of the time, 3, bedridden more than 50% of the time, 4, completely bedridden. This is Eastern Cooperative Oncology Group performance status. That's BS for performance status, and Eastern Cooperative Oncology Groups. Okay, we have high, this is a poor prognostic factors of RCC. We have higher ECOG performance status, symptomatic tumor, high stage tumor, large tumor size, collecting system invasion, high grade tumor, sarcomatoid fissures, or high grade tumors and sarcomatoid and tumor necrosis, microvascular invasions, histology of prognosis worse for collecting, medullary, type 2 papillary, and unclassified. This is a histology have a poor prognosis. The medullary is worse than collecting, type 2 papillary is worse, and unclassified is another. High level of tumor thrombus or tumor thrombus invading the vena cava, or residual tumor incomplete section or positive margins, or presence of MITs. Survival based on normogram. Normogram can be predict metastasis for free survival and cancer-specific survival for patients who undergo partial or radical nephrectomy for RCC. This is survival based on UCALA integrated staging systems. We have 2017 TNM stage, that's T1N0M0 and T2N0M0 and T3N0M0 and T4N0M0 and N1M0, only one node MITs, or N1M0 more than one MITs, or M1. This is the TNM. And T1 with no lymph or MITs 0, that's 0, 0 more than 1. This is the ECOG BS. Or 4 months, grade 1 to 2, 3 to 4, any grade with TNM more than 1. Or T2N0M0, any of ECOG or any of 4 months, so this survival here is 80%, as well as the TNM stage with this group and 4 months, 3 to 4, and more than 1 or equal. All this is, as you see, the survival, 5-year survival specific is 80%. But remember 0, that is 4 months, 1 to 2, it's 91%. And it's treated by radical nephrectomy, as well as all others of T2 and T3 and 0 with ECOG 0 or ECOG more than 1, or 4 months 1 or any 4 months, this is T3, all this can managed by radical nephrectomy. But remember the T3 with more than 1 ECOG and 4 months more than 2, here the percent is 55%, and also it's treated by radical nephrectomy, as well as T4 and 0M0, any the survival is 55%. This is for T4 with any first man or any ECOG BS. So it is 5-year survival, and radical nephrectomy is an option. If the patient have only 1 lymph nodes with any ECOG or first man grade, any first man grade, the survival is 32, and the manage is radical nephrectomy plus or minus immunotherapy. The nephrectomy, if thrombus, will do thrombectomy, was performed when the tumor thrombus is present. And N1 with M0 or M1, that's, for example, 0 and 1 to 2 4 months or 4 months, 32% 5-year survival, and management is radical nephrectomy. And we have the last, this is the 0 to 3, 0 ECOGs, BS, and 4 months 3 to 4. This is 20% compared with more than 1 ECOGs more than 1 or and 4 months of 1 to 3 if there is any lymph node, 1 lymph nodes or MITs, that's the survival is 2%, and management is radical nephrectomy plus or minus immunotherapy, and the last more than or equal 1 ECOG with 4 months 4, survival rate is equal 0. This is survival based on TNM states. T1A survival rate is 90 to 100%. T1B survival rate 88 to 92%, and survival rate for T2 without lymph node or without lymph nodes is 88%. Remember, T1A and T1B we will do a radical or partial nephrectomy, and T2 we will do directly radical nephrectomy, and this is known as the pathological stage American classification for the tumors. This is a 5-year survival, as you mentioned it, 95 to 100, 88 to 92, 88 to 88% for T2. This is the pathological stage. T3A and 0M0 in the perirenal or sinus fats, but no venous tumors, thrombus, radical nephrectomy. The survival is 47 to 68. This is according to the pathological state. And T3 and 0M0 with tumor thrombus in the invasive vena cava or vena cava, we do radical nephrectomy and thrombectomy. The survival rate is 43 to 72%. And T4 not into the contiguous regions, this is actually radical nephrectomy and 28% survival rates. T4 into the contiguous organs, this is radical nephrectomy and survival rate is less than 5%. And T1 and M0 will do radical nephrectomy and survival 0 to 33%. And if solitary recurrence develop after nephrectomy for M0 treatment of recurrence, the survival is 13 to 54. Thus, here it's actually most die within 2 years of diagnosis. These patients have worse survival than the patients that develop solitary MITs. Solitary MITs present at initial diagnosis, radical nephrectomy of treatment, radical nephrectomy and treatment of metastasis, and 0 to 20%. This is survival, as I mentioned, most die within 2 years of prognosis. The last multiple unresectable metastasis will do any therapy. Survival rate is 0. Recurrence after survival after partial or radical nephrectomy, local recurrence in renal fossa is less than 2%. Resection of the local recurrence in the absence of metastatic disease can be acute long-term survival. In the absence of the genetic or familial RCC syndrome, the recurrence in contralateral kidney is rare, 2 to 4%. Lung is the most common site for the distant recurrence. Most recurrence occur within 3 years of treatment. And this is the end of renal tumor part 3. Thank you very much.